Hi, everyone. Welcome to today's Student-Led Journal Club seminar series. My name is Anne-Marie Hayes, and I'm a research associate on the Joplin campus of KCU. Today, I will be introducing our speaker, student Dr. Celeste Murtha, who's going to be talking about her cadaveric study that she's been doing as an anatomy fellow here at KCU. So, to introduce our speaker, Celeste Murtha is nearing completion of the Anatomy Fellowship on the Kansas City campus and is looking forward to rejoining the clinical community this summer as a fourth-year medical student. She completed her undergraduate studies at Colby College in Maine, where she earned a bachelor's in biology. Before starting medical school, she worked for a healthcare consulting firm where she had the opportunity to support clients at various pharmaceutical and biotechnology companies. As Celeste enters her last year of medical school, she is interested in pursuing general surgery with a special interest in vascular surgery. In her free time, she enjoys cooking and baking, running, and spending time with her family and friends and dog, Nickel. So with that, the floor is yours, student Dr. Murtha.
Thank you. Thank you for joining everyone today. Today, I will be presenting a study entitled A Cadaveric Study Evaluating Intraluminal Abnormalities of the Left Common Iliac Vein. I want to recognize those who have supported me throughout this project with their guidance or help with data collection and such. So that is Dr. Coates, Grace, Morgan, and Dr. Olinger. Okay, before we dive into the specifics of my research project, I want to orient everyone to the anatomy that we'll be discussing today, which is the pelvic vascular anatomy. Along the left side of the spinal column, we have the descending aorta before it bifurcates into the left common iliac artery and the right common iliac artery. On the more rightward side of the spine, we have the inferior vena cava, which ascends towards the heart, and the inferior vena cava is formed by the confluence of the right common iliac vein and the left common iliac vein. What I really want you all to pay attention today is this region right here. So what you see here is the right common iliac artery descending down into the right lower extremity to perfuse it. And as it's doing that, it is running over the left common iliac vein. And this area right here is the foundation for a syndrome that we call May-Thurner syndrome. So May-Thurner syndrome just describes an anatomical variation in which the left common iliac vein here is compressed by the right common iliac artery and the lumbar vertebrae. And it's usually the fifth lumbar vertebrae. However, that is a bit variable. So what you see here, this cross-section on the right side is a great depiction of what's happening. You have basically a left common iliac vein sandwich. And based on what we know about arteries and veins, we know that veins are much more compressible due to a less substantial medial or muscular layer. So it makes sense that the vein is compressed by two structures that are harder and more robust. In addition to the venous compression we see of the left common iliac vein, the other finding associated with May-Thurner syndrome is the development of intraluminal spurs or adhesions. Those are interchangeable words. And I'll be using both throughout the presentation. So if you can imagine, one, venous compression, and two, the development of these spurs within the lumen of the vein itself, they lead to a decrease in luminal caliber, and they impair venous outflow from the left lower extremity. And as you can imagine, that leads to an increased risk for thrombosis in those patients. One thing I want you all to be aware of is that syndromes similar to May-Thurner syndrome can occur in the right lower extremity, can occur in the right common iliac vein, although those are rare and not the focus of today's conversation. Given that the right common iliac artery crossing over the left common iliac vein is actually normal anatomy, what you see here, I'm sure you're all wondering, okay, well, does everyone have May-Thurner syndrome? And the answer is no, definitely not. Most individuals actually have enough space in this region here and here that the vein does not undergo any significant amount of compression. Okay, in terms of disease epidemiology, it is believed that May-Thurner syndrome affects about 20 to 30% of the population. However, symptoms manifest in only a very small portion. And for that reason, it's actually thought that this prevalence is an underestimation. To give you a sense of the asymptomatic nature of this disease, a study in 2004 conducted by Kibbe et al. Conducted a retrospective analysis of abdominal and pelvic CT scans in an asymptomatic population of 50 individuals. And among those individuals, Kibbe et al. Found that there was significant venous compression, specifically the left common iliac vein, in 12 of those 50 individuals, which amounted to 24% of that population. And that aligns nicely with the current prevalence estimate for this disease. So you're probably all wondering, okay, well, why does this disease manifest in so few people? And it's likely because our bodies have really great compensatory mechanisms, which include the formation of collateral veins. So in a lot of individuals, our bodies are able to circumvent this obstruction through the formation of collateral veins. In terms of disease presentation, those that are clinically affected by the disease most often present with a deep vein thrombosis. Something I want to bring your attention to is the fact that a DVT is a relatively common diagnosis in the emergency department setting, or really even in a primary care setting. And in a lot of cases, clinicians are going to look for the most common risk factors that lead to a DVT. So that could be use of oral contraceptives, recent immobilization due to a handicap or surgery, recent long plane ride. And so if a clinician finds that an individual has that risk factor, they're not going to keep digging for other reasons as to why that patient may have developed a DVT. So that's another reason why I think the prevalence estimate we have up here is an underestimate, is because a lot of times clinicians aren't digging for this very specific diagnosis. So again, in terms of presentation, these patients are going to be presenting with left lower extremity edema, swelling, pain, and enlarged circumference. It's thought that the disease is responsible for about 2 to 5% of DVTs, and it most commonly presents in females in their 2nd to 4th decade of life. In terms of diagnosis of May-Thurner syndrome itself, that typically relies on more invasive imaging called intravascular ultrasound. However, it can also be detected with a CT or MR venogram. In terms of treatment, long-term anticoagulation usually is not sufficient. These patients usually require surgical intervention with the placement of a venous stent to ensure long-term patency. Okay, let's talk a little bit more about Spurs themselves. They were first documented by an anatomist named Dr. McMurk in 1906. He defined these as a fusion between the anterior and posterior venous walls that lead to a decreased luminal caliber. If you look on the right side of this slide, these two diagrams are actually from Dr. McMurk's 1906 manuscript, diagrams that he drew of the spurs that he observed. The solid black shapes represent the adhesion itself, with a straight line representing the axis that the adhesion occurs along. I actually find that the cross sections are the most helpful view. So as you can see here, this is a columnar adhesion that essentially bisects the lumen and creates 2 different tunnels that blood can travel through. And I'll talk a little bit more about this classification system shortly. Dr. McMurk's work involved the examination of explanted iliac veins in 107 cadavers. And he found adhesions in 32.7% of those cadavers, 91.4% of which were left-sided. He subsequently developed a classification system based on spur morphology, which you saw a little bit of in the prior slide. He also theorized that spurs were congenital and were due to failed involution of some embryonic vessels. And he lastly theorized that the greater frequency of left-sided DVTs was due to the preponderance of these left-sided spurs that he discovered. So this greater frequency of left-sided DVTs was a well-known fact at the time. It was actually established by Dr. Virchow in the 1850s. And so I think it's pretty noteworthy that Dr. McMurk, an anatomist, was able to make this connection, even though May-Thurner syndrome as an entity had not yet been established. Okay, I want to highlight a couple of other major markers in the May-Thurner research landscape so that you guys can all understand how my research fits in. So in 1906, I mentioned Dr. McMurk was the first to document spurs. About 35 years later, Dr. Eric and his colleagues came along And they actually suggested that spurs are acquired versus what McMurk had thought congenital. And Dr. Eric thought this because all of the spurs that he observed within that left common iliac vein were occurring at the point that the right common iliac artery crossed over it. About 15 years later, May and Thurner came along, and they took Dr. Eric's theory one step further, saying that adhesions develop due to mechanical compression and arterial pulsation by the overlying right common iliac artery. This has now become the dominant theme or the dominant theory behind this disease. And they made such a splash in the field that they are the namesake for the condition. About 10 years later, Dr. Cockett, a British vascular surgeon, came along, and he established a relationship between compression of the vein and post-thrombotic syndrome, which is a suite of symptoms that develop weeks to months after an individual has a DVT. And more importantly, he was actually the first to report on May-Thurner syndrome in live patients. And for this, he became the namesake for the disease in Europe, Cockett syndrome. And then more recently, Mitsuka and his colleagues in 2014 conducted histologic research that suggested that May and Thurner's theory of spur acquisition is valid, but also suggested that adhesions may be secondary to other mechanisms as well. Okay, so I want you all to keep in mind that the current theory of spur formation is that chronic pulsation of the right common iliac artery causes intimal hypertrophy and hyperplasia within the left common iliac vein, leading to spur formation. And on histology, these spurs tend to appear as bands of fibrosis. So given all this background, my objectives were to evaluate the prevalence of spurs and compare that to prior researchers, to categorize spurs by morphology, and to take that one step further by providing photographic evidence of these spurs. And all of the literature review that I had done, there was very few high quality pictures showing gross anatomical pictures of the spurs, which I'm sure you can imagine based on how old some of the research is. So pictures from 1906 don't quite measure up to the type of pictures that we take today. And then lastly, I wanted to explore whether certain factors that are inherent to the cadaver are associated with spur development or presence. And so I looked at cadaver sex, BMI, the presence of plaque in the overlying right common iliac artery, and lastly, the level of the iliac vein confluence. Okay, so my population of interest involved formalin and balm cadavers at the KCU, Kansas City, and Joplin campuses, in addition to the University of Nebraska Medical Center. Consent was obtained through donor participation in each of the respective gift body programs. At the time of data collection, cadaver age, sex, and BMI were all recorded. In order to collect our data, we first exposed the abdominal aorta, the inferior vena cava, and the bilateral common iliac arteries and veins. Luckily for us, across all campuses, the student dissectors had completed the majority of the GI and GU dissections, so a lot of the structures were cleared off for us. We just had to do a bit more cleaning. Next, we determined the spinal level that the iliac vein confluence occurred at. So to do this, we looked at the location of the left common iliac vein right here and the right common iliac vein right here, which is sitting under the artery, and we assessed what spinal level the confluence was occurring at. To help us with this process, we placed colored pins as benchmarks. So we always use the red pin to mark the L4, L5 disc space and the blue pin to mark the L5, S1 disc space. And so in this cadaver, you can see that the iliac vein confluence is occurring at the L4 level, just above the L4, L5 disc space, which is actually higher than what we observed in most of the other cadavers. We then observed the point at which the right common iliac artery crossed over the left common iliac vein. Luckily for us, in all of the cadavers we examined, this occurred at the junction of the left common iliac vein and the inferior vena cava, so we didn't really have to take any particular measurements, which made data collection a little bit easier. We then transected the common iliac arteries along these lines to better expose both the left and the right common iliac veins. Before transecting the right common iliac artery, we palpated the artery to determine if we could feel any plaque presence, and that was noted. And then again, after transecting the artery, we examined the lumen of the artery to determine if we could see any plaque presence, and again, that was noted. Next, we injected wetting solution into the left common iliac vein to encourage dissolution of congealed blood that was remaining from the embalming process. So where we injected was right where this triangle is pointing. We then made 2 incisions in the venous structures. The first incision was made along the right lateral margin of the inferior vena cava, extending down into the right common iliac vein. And the second incision was made perpendicular to that along the axis of the left common iliac vein. And that incision really helped us to visualize the lumen of the left common iliac vein to determine spur presence. I will say that this part of the methods was significantly informed by the methods established by Mitsuka et al. In 2014. Lastly, the lumen was examined for spur presence. Spurs were documented and photographed. In terms of statistical analysis, we used SPSS to conduct the analyses. Logistic regression was used to assess the relationship between adhesion presence and sex, and also the relationship between adhesion presence and plaque presence. And then a chi-squared analysis was used to assess the relationship between adhesion presence and BMI category, and adhesion presence and the location of the iliac vein confluence. Okay, let's talk about results. In terms of cadaver demographics, we collected data from 51 cadavers, 27 of which were male and 24 of which were female. So we were lucky that we had a pretty great male to female distribution. The mean age at death was 74.1 years old with a range of 36 to 90 plus years old. And the mean BMI at death was 24.3, which are with a range of 13.9 to 34.9. Of note, we are not able to obtain the BMI data in 2 cadavers. And so for that particular analysis, we used a sample size of 49 versus 51. In terms of spur prevalence, we observed spurs in 16 of 51 cadavers, which is equal to 31.4% of our population. All spurs were located at the point that the right common iliac artery crossed the left common iliac vein, which is consistent with what Dr. Eric suggested in 1943, it was, I believe. If you look below in this table here, I wanted to provide a side-by-side comparison of the prevalence we found in our study versus past researchers. Up here, we have our sample size of 51, and down here, you can see our prevalence of 31.4%, which is pretty comparable to past research studies, which prevalence ranges from 14% up to 29.9%. So we're right in that ballpark. What you'll probably notice is that some of the past researchers had really robust sample sizes. We didn't quite measure up to that, but that is okay. In terms of the classification of spurs, this is based on Dr. McMurrick's classification that he developed in 1906, which was further modified by Dr. Eric. So the most common type of spur that we observed was a marginal and triangular spur that sat along the lateral margin of the left common iliac vein with the apex pointing towards the center of the lumen. While Dr. McMurrick observed this in 32% of his population, we observed it in 67% of our population. So that's a pretty big difference there. The next most common spur that we observed was a columnar spur that essentially bisects the lumen and creates 2 tunnels for blood to travel through. Dr. McMurrick observed this in 44% of his population, while we observed it in 25% of our population. Next, we observed marginal and linear spur. So this is a narrow, long adhesion on the lateral border of the left common iliac vein. We only observed this in 1 of our cadavers, so 6% of our population, whereas McMurrick observed it in 15% of his population. And then lastly, a complex spur type. So this is actually a new category that we developed because none of the prior categories that McMurrick or Eric described fit what we observed. So we define this as a variable phenotype, but with synechia present. And I will show you all a picture of that shortly. And we observed that in 1 of our cadavers. Okay, so let's examine some gross anatomical pictures of the spurs that we observed. This here is a marginal and triangular spur. To orient yourself, we are standing along the right side of the cadaver, looking down into the abdomen. The inferior vena cava is running down this way, splitting into the left common iliac vein and the right common iliac vein. And if you focus your attention here, you can see a triangular spur. It may take a little bit of imagination, but let me help you out there. This right here is the apex of the spur, and this right here is the triangular region of the spur. And as you can imagine, this one isn't super remarkable. As you can imagine, this would obstruct blood flow and at the very least cause turbulent return of blood flow. Next, let's talk about columnar spur. So let me orient you again, standing at the right side of the cadaver and looking down diagonally into the cadaver. So this right here is the inferior vena cava coming down with the left common iliac vein there and the right common iliac vein here. And if you focus your attention on this pin, you can see this spur here that separated the left common iliac vein into one lumen there and a much larger lumen here. The next type of spur is a marginal and linear spur, which stretches from about right here to about right here. And the best way for me to help you guys visualize this adhesion is to appreciate that right where my laser pointer is the lateral margin of the vein, but yet we were not able to open the vein beyond this point. So you can imagine or appreciate that this portion of the vein, the posterior and anterior walls, were adhered to each other. And then lastly, and most impressively, in my opinion, is a complex spur. So these here are synechia, these little webs that extended from that kind of muddled or obscured the opening. And you can even see some pieces of blood that we were not able to effectively clean out because of the synechia. And then also remarkably, it was extremely stenotic opening. So this is a 4 millimeter opening compared to the typical opening into left common iliac vein of about 1 centimeter. So to make sure that you guys are looking at this the right way, we are looking down into the left common iliac vein from kind of the shared compartment of where the left common iliac vein, right common iliac vein, and inferior vena cava meet. One thing I want to point out to all of you is that we did not classify venous valves as a spur because venous valves are normal anatomy. Based on the reading that we've done, spurs are consistently present at the inferior junction of the left common iliac vein and the right common iliac vein. So this right here is a venous valve right at the inferior portion of where these two veins are meeting. We observed these in 37% of our cadavers. And while most people should have venous valve in this area, I think a reason that we didn't really observe as many as one would expect, I would expect that we would have them in all of our cadavers, is because we know that venous valves degenerate with age, and given the older age of our cadaver population, it's likely that these were degenerated in a lot of patients. Okay, let's talk about the statistical analysis. When evaluating the relationship between adhesions and cadaver sex, males were 73% less likely to have an adhesion. If you focus on the raw data over here, you can see that adhesions were observed in 5 males and 11 females. So you can appreciate that females had just about double the amount of adhesions present. This is consistent with the literature, which suggests that May-Thurner syndrome is much more prevalent in the female population. When examining the relationship between adhesions and premortem BMI, we found that there was no significant difference in the presence of adhesions among the different BMI categories. So we placed each cadaver into one of 4 BMI categories, and doing that, we found no significant relationship. I personally found this to be surprising. My theory going into this was that patients of greater BMI would have greater intra-abdominal pressure, and that greater intra-abdominal pressure might exert more force onto the left common iliac vein, but that is not what our results suggest. Something to note here is that the BMIs we used were pre-mortem or at death BMIs, and it's possible that the patient's BMI is not representative of what their BMI was throughout their life, and or that spurs develop at a much earlier period in one's life, and that the BMI at an earlier point in one's life is not the same as a BMI later in someone's life. So just some things to keep in mind with this analysis. When looking at the relationship between adhesions and plaque presence, we found plaque in about 65% of the cadavers. However, there was no significant relationship between presence of plaque and presence of spur. I found this to be the most surprising. I had theorized going into the project that presence of plaque in the overlying right common iliac artery would increase compression on the vein and therefore lead to a greater development of spur in the underlying vein, but that is not what the analysis suggests. And so maybe this suggests that plaques are protective against spur formation. So the way I now think about this is, if you think about a plaque in the artery, it's not fully circumferential, but it's like a shape like this. And I think of it as almost a protective barrier. So that plaque, it adds another barrier or another layer to the artery that prevents the transmission of the arterial pulsation and mechanical compression of the artery beating with each heartbeat. That may actually protect the vein from developing that spur. However, it's important to note that the high frequency of plaque burden in our population may skew these results, and that's likely because of the older age of our population. I think it could be worthwhile to look at this relationship in a younger population. And then lastly, looking at the relationship between adhesions and the iliac vein confluence, we found that a significantly larger percent of adhesions was found within cadavers with an iliac vein confluence located at the L5-S1 level, suggesting that spurs are more common when the confluence occurs at a lower spinal level. And to me, this suggests that the anatomy of the left common iliac vein and the path that it travels in individuals with a lower iliac vein confluence may make the vein more vulnerable to compressive factors, to stronger compressive factors. In terms of limitations, May-Thurner syndrome unfortunately cannot be diagnosed in a cadaver. It must be diagnosed in vivo. So for those in whom a spur was identified, we cannot definitively say whether the spur was associated with May-Thurner syndrome, although I am not personally familiar with any other conditions in which we observe spur formation. In terms of next steps, I think it could be interesting to better classify the plaque burden. So in my study, I used a dichotomous yes/no variable, but I think it could be helpful to create a scale of no plaque burden, light, moderate, and heavy plaque burden, and see if there's a relationship there. I also think it could be interesting to examine for the presence of osteophytes along the lumbar vertebrae and sacrum. I theorize that osteophytes in the bony part that compresses the posterior aspect of the vein could contribute greater compressive forces and lead to greater development of spurs. In terms of conclusion, adhesions are more common when the confluence of the common iliac vein occurs at a lower spinal level. So the level of the confluence may indicate that the anatomy of the left common iliac vein in individuals with an L5-S1 confluence may be more conducive to spur formation, and clinically, this may be important in identifying patients at increased risk of intraluminal venous disease. Plaques within the right common iliac artery cannot be used as a diagnostic predictor in detecting patients with adhesions. And lastly, and importantly, further investigation is needed to continue to understand the factors that contribute to adhesion formation. And that's it.
Awesome. Thank you so much, student Dr. Murtha. Great presentation, great job, amazing visuals. You did a really good job walking through everything and being very clear and articulate on all of the diagrams, everything you wanted us to look at. If anyone has any questions, feel free to either raise your hand in Zoom or you can go ahead and unmute and go for it. If you can't talk right now, you can also type any questions in the chat and I will read them out loud so that they are in the presentation. Yeah, any questions, comments? Dr. Dobson, you have a question?
Hey, thanks. Celeste, I like that. That was very nice. Did the patient with the mixed spur that you showed a really great view of, was that patient symptomatic? Do you have any medical records to talk about lower extremity issues in that patient or no?
I really wish we did. We don't have comprehensive medical records for these patients, but I'd have to guess that patient had significant left lower extremity symptoms. And if he didn't, he must have an impressive collateral venous circulation. But yeah, when I saw that patient, I really wish that we could have had medical records.
Was there downstream thrombosis in that patient at all, or impossible to tell at the time of dissection?
Yeah, it's really hard to tell
Okay.
after a cadaver is embalmed, just because all of the blood becomes so congealed, and sometimes the blood dries out and looks like maybe it was once a thrombus. But I presume that without histological analysis, we wouldn't be able to tell.
Yeah, impressive picture. Thank you.
Any other questions, comments? Dr. Wolf?
I was going to compliment you, I guess, for doing an impressive job of predicting all my expectations as I heard you start off what you were interested in looking at. I mean, I would have thought exactly the same thing as you did. And I was curious whether or not, and you addressed this a little bit with you're seeing them after they may have had a different body type before they died, but you know, the apple versus the pear or something like that. I was wondering if the distribution of the body weight may have also contributed.
It's a great question. I have no idea and cannot speak to that because I didn't look at distribution of body weight, but I think that's a great idea for our next step. Something I didn't quite elaborate on is the theory of when spurs develop, and it's thought that the majority of spurs develop in like the late first decade of life or during the second decade of life. So I think that would be the most appropriate time to look at that relationship between BMI and spur development. But again, that relationship isn't clear yet as to when spurs do actually develop. But the current theory is that most patients are not born with them and they develop at some point later in life.
Any other questions, comments? These are great discussions. Good questions, everyone. If not, thank you so much, student Dr. Murtha. Again, wonderful presentation, wonderful discussions. Well done.
Thank you.